John, tell us a little bit about our special guest today.
Yeah, so we have been continuously trying to bring to you, obviously, high quality content and some of the best speakers in implant dentistry. And we have another one of those here with us today. Dr. Ole Jensen, thank you so much for being with us today.
You bet.
Yeah,
excited.
We're glad to have you here. Talk a little bit about yourself, for those of you who maybe aren't familiar with you. Tell us about what you do, a little bit about your history, and what you're up to these days.
I like to try and be as brief as possible. I'm an oral maxillofacial surgeon, came out of the University of Michigan, went into private practice in Denver, Colorado. Initially did cancer surgery for about 6-7 years, and then gravitated towards dental implants and have been interested in reconstructive surgery, and eventually got involved with different aspects of treatment, including the complete arch treatment, which is one of the focus I have right now.
Yep. So let's talk about that concept. Complete arch treatment has been a continuous evolution over many, many years now. And of course, you were involved with some of the pioneering of getting the concept out there in a systematized way. And I want to talk about that. What are some of the aspects of that have changed the most, say in the last 10 years that you've seen, talking about things like material selection, number of implants, kind of some long-term management. How are you seeing that evolve?
One of the things you have to understand with implant dentistry is that it has been the Wild West. We have been sort of left out on our own to try and figure it out. We didn't have guide systems or even, early on computer analysis that was very good. And so a lot of dentists, surgeons and so on were kind of reinventing the wheel in all kinds of different places around the country and around the world, really. And one of the areas that was kind of interesting to me and continues to be is the sinus floor augmentation bone graft. That was a very, very controversial thing, and it's only been accepted maybe, 15, maybe 20 years or so. So that you think about that, it's been very recent that we've developed so many things that now just seem commonplace. As far as the full arch goes, now with the guidance systems and the digitization of the processes and the selection of materials, and now I don't want to be offending to anybody, but it takes very little thought process in order to do our treatment compared to what it was 15, 20 years ago. So that means that the systemization, the stuff that I had developed in the early 2000s, becomes a little less important because you can rely on the computer analysis.
Mm. As we're chasing the edentulous patient these days, and really end-stage dentition, our baby boomers are reaching the point, and have been over the last 5 to 10 years, to where we're replacing teeth with prosthetics. And what have you found, now that you've been doing this a while, is predictable? And then what maybe have you revised since you started doing these treatment options?
Well, predictability from a surgeon standpoint is to, not to oversimplify, but to make sure that the implant is in bone and that it's centrally located and that it has protection, and also that it's fixed in bone. So in order to do that, you have to find some cortical aspect that the implant goes in. In other words, it has to go in tight and stay tight and be tight long term. But the things that are being done now a lot of times are missing basic biological principles, such as putting an implant where half of the implant is not in bone. and then bone grafting and so on. And these things you do have to do sometimes, but it adds risk to the case. And if that bone graft should be lost, such as with a smoker, for example, then you would get long-term, loss of bone and eventually losing the implant. So the basic principles of implant care is to get that implant well in bone.
Mm-hmm. Mm-hmm. Now, you mentioned that things have become easier, as you say, from a standpoint of planning and guiding. So with that in mind, does that create more problems, though, than it solves in certain ways? It sounds like, on the other hand, we hear you saying, but, we're not getting implants in bone, per se. We're missing some biologic principles. So is it the principles of freehand surgery, of understanding how things are supposed to feel, how things are supposed to look? Have we lost that along the way? Are we seeing that maybe we're relying too much on technology?
People have asked me, how do you know that you can put the implant in there, or that you can cut the bone in a certain way? And that comes from experience, but not having to do that now is an interesting question. In other words, can the new doctor who is getting his experience analyzing the CAT scan and having kind of different input into his brain and experience, can that person, that he or she, can they do as well as somebody who's, just had experience and different, methods of approach to putting implants in? I think it's going to be better. The approach of the digital world, learning things, say with augmented reality, for example, it's going to be magnificent. And then I'll give you an example. I'm an adjunct professor at the University of Utah, and one day the computer lab people came out and they said, we want to show you our augmented reality of a tooth. And so I put on the glasses, and the tooth was sitting here in front of me, and they sectioned it out. And what we were looking at was the root canal, or the roots, the endodontic nature of correction of a tooth. And I was able to see the arborization of the canal of the tooth, and it reminded me of a river with all kind of a delta, and the exactness of it was, and the three-dimensionality of it was so amazing. It opened up my mind in a way that all my experience in the past didn't. And so I just give that as an example. And I know augmented reality, probably only a handful of dentists have even done it or seen it. And we actually at Utah did the first augmented reality implant placement. And the doctor, who was Nate Adams, put the implant in. He could see the nerve at the entire time, with this.
Right. So this is navigation system taken to another level.
Yeah, this is not navigation, but using augmented reality. But the only reason I bring it up is the learning of the brain is different now. We were in the hunter-gatherer world, clubbing our implants. Now, as a matter of fact, I had one implant system where we tapped it in, to now where we're much more high technology, and so I don't think we need to look back, but look forward.
That's amazing. I think one of the things that has helped you develop these systems is bringing people together in the practice. You're bringing the restorative clinician together with the surgeon, the prosthodontist, the restoring doctor per se, and then those two working together.
And the lab technician.
And the lab technician as well. I mean, you have that team of three there, and your treatment planning together. And how is that kind of compare and contrast the advantages of that compared to maybe more private practice model where we have to kind of piecemeal those things together and finding all the right pieces?
Well, there's something happening here that we don't quite understand, and that is that we're coming together in this, and then we're going apart at the same time. Mm-hmm. Let me talk about collaboration. What I learned early on, and when we started Clear Choice, for example, that started in my private office.
Sure.
And I didn't know about how to do the prosthetics. I didn't know how to do the laboratory. I didn't know how to bring patients in. And yet I was in a private practice. I was trying to do all that on my own. But when we were trying to go and scale, I needed help. And all these individuals that came in and together to support this this team approach, I really learned and came to appreciate everybody's role and what they could do. I would say the Academy of Osseointegration has been and continues to be a team approach to dentistry. We cannot do it. We can't know that much on our own. I know a lot about surgery, but I don't know a lot about periodontics. I don't know a lot about endodontics. I don't know a lot about prosthetics and laboratory work and all that. I mean, that amazing stuff. That has to be brought in to help me do my work. So having said that, and the great success that Clear Choice clinics and clinics like that have had, what's happening now is that we're kind of changing and going into a solitary model. So it's interesting that this team approach is maybe escaping us because the technology allows us to be almost single operator in our approach. And one of the things I talked about yesterday was this technology of photogrammetry, or if we can just take a picture and not have to deal with, our impression mode, and the picture of our implant placement is more accurate than a dental impression, and that's all digitized and can be done with placement the next day or the day after, then you start moving away from this requirement of having a team approach to a more solitary delivery system. So that's going on at the same time. So there's these two kind of competing things happening.
Yeah, John, we've got a question from one of our listeners, Dr. Mark Ludlow. And as you're talking a little bit about this team approach, there's a lot of preoperative planning that's done prior to. In the case of immediate extraction, immediate placement, where we're placing, multi-units on, we're pre-planning or maybe even designing abutments prior to the surgery, and we deliver the implant, the abutment, and then the provisional temp prosthetic goes in, and then there's a healing phase, right? And during that healing phase, there's soft tissue changes, maybe even hard tissue changes because we have taken teeth out. I guess the question is right, because we've already spent the time, right? How do we manage, right, the resources and all the time, and how do we manage contour changes? Like, who really owns that, right?
Well, the last person to touch it owns it.
Tag, you're it kind of thing. Mm-hmm.
You do a bone graft, it doesn't stay there.
Mm-hmm.
I mean, we hope it mostly stays there, but I was listening to some of the speakers and for example, one of them said, I always put the implant in a couple millimeters or a millimeter or so below the top of the bone graft, expecting some
loss,
some
right.
resorption. And then you see another person talking about soft tissue and saying, well, you need to get very, very thick, non-fatty tissue if you're going to do a soft tissue graft so that the end result, it doesn't shrink down and disappear. And then, the use of your intaglio surface and so on needs to be adjusted. We're dealing with biology. We're dealing with the human body. It's changing. It's going to change in the first 6 months. It's going to change in 5 years. It's going to change in 10 years. You have to be vigilant, and you have to take care of your patients. You have to watch over them. And if somebody loses a tooth, you have to add something. If somebody loses soft tissue, you have to do something about that. So I think it's basically not a guessing game. It's a game where you're taking care of people and taking care of the shifting sands of their care.
Yeah,
right.
Yeah,
it's part of the process you own, right?
Right. And I think that question stems from the fact that we're seeing, obviously this simplification, as you say, about the, what we can do in terms of delivering a, not just a provisional prosthetic, but a definitive prosthetic within 2 to 3 days, which is amazing. Then we see changes, and sometimes maybe we overpromise that this is the definitive prosthetic, and then we have to manage that as time goes on. And it just sounds like you're saying we just have to know that that's the way things will go and take care of our people.
Right. And just let me just say one other thing on individualization. So sure, I was involved with a clinic system where we tried to do a standardized approach, and that is, the all-on-4 where you do bone removal and so on. And I understand that, but that it's a successful way of doing something, and I don't criticize it. We should, as we go forward, think about individualization. In other words, what is the best thing to do with a certain patient? Maybe they're in their 3rd decade of life. What's the best thing we can do for this person that might live 70 more years, or at least 60 more years? And what about somebody that's 50? And what about somebody that's 80? What about somebody that has a lot of bone, somebody that doesn't have very much bone? What's the best thing for them as an individual? That's something I think that the field is really, green for us going forward. We're going to be able to talk about that and learn, what's best to do for patients. And I think what we've gone through now is a period of time where we're kind of promoting a certain technique. Like when I first started doing implant dentistry, what we promoted was 2 implants for an overdenture.
Right.
And so that's what we talked about, and that's what we kind of promoted. And then we went to, all the other iterations. And so I think going forward, I really like the idea of really analyzing a patient and then also finding out really what they want. The patient's desire, the psychosocial aspect, that's so important. And I hate the idea of us kind of commanding from on high what we think is best for them.
Do you think that there will be a time where, as you say, we're becoming almost more of a single operator idea because we're able to virtually design a lot of our prosthetics, our guides? The lab becomes almost can become sort of a cloud-based situation. Do you see that changing the dynamic of, say, a clear choice type model where we're having, that scalable in a different way, where it's more of the resources available to the clinician to where they can perform all aspects of treatment with the lab kind of in the background as opposed to in-house?
Yeah, think no lab work, elimination of the lab. Think printing and all the devices that you need sitting on your table. Think about technologists. Think about computer, people running your computers, rather than somebody in the lab waxing up a tooth. It sounds very remote, like, hey, this is 20 years away or 10 years away. It's not remote. But what we do with it is an important question, and how the Academy of Osseointegration and dentistry at large handles this aspect is going to be interesting to see. And maybe it is going to require still a lot of talent and a lot of judgment. And therefore, one person can't do that. One mind can't know what to do in all the different settings. And so maybe we will have some kind of a team approach, or even like they have in cancer centers, where you have a committee that establishes cancer treatment. So not one doctor, but a large group of people figure out, okay, we're going to do this, then we're going to do this, then we're going to do this. And maybe that kind of a tap in of information will be available, and but will be part of future care.
I think the last question to kind of sum up the interview is really a question that really is on a lot of people's minds. And as we've noticed, general practitioners moving into the placement realm in the United States, whereas in our international situations, GPs have been placing the majority of implants for years. Should GPs be involved in complete arch treatment?
I think they should. I have a dental implant company, Ditron Dental Implant Company, and half of our customers are general dentists. They're excellent. They sometimes they're called super GPs. I think they're very capable of doing that. The leaders in implant dentistry over the years, a lot of times, have been general dentists, such as Paulo Malo, such as Hilt Tatum. Then you have people like Branomark, who wasn't even a dentist. So, let people be who they are and who they can become, not so limited by degree. However, having said that, I come from the school where I think that extra degrees such as oral surgery and periodontics and prosthetics has a great advantage, and I really like the way those guys, that group of people, treat patients.
Very good. Very good.
Well, this has been excellent conversation. Thank you for being with us and giving us some idea about what the future might bring.